Hi, everyone. I'd like to do a shout out to our sponsor, Bako Diagnostics. Early detection is the single most important factor in improving patient outcomes. The Bako Diagnostics team recognizes how impactful a podiatric physician can be and remains committed to supporting you in your role as the first line of defense in diagnosing conditions of the lower extremity. Thanks to the unwavering support of our clients, Bako Diagnostics has been able to give back to the podiatric community for 16 years by providing podiatric educational resources and advocating for the profession. Bako Diagnostics, helping podiatric physicians keep America on its feet. If you have not yet had the opportunity to utilize Bako Diagnostics services, get started today by sending an email to corporaterelations@bakodx.com. The first 50 podiatry offices who request a starter kit will receive a Dean's Chat. Hello, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Once again, I'm joined by my co-host, Dr. Johanna Richey. Hi, Joe.
Hey, Jeff. How you doing?
I'm doing fabulous. How was your long weekend?
Oh, it was absolutely lovely. My sister came over and we had a big family holiday, Thanksgiving. It was really lovely.
Oh, fantastic.
How
Well,
about you?
I've been doing great too. Yeah, we were in Wisconsin. It was a little cold. I'm glad to be back in Arizona.
Yeah.
Hey, we've got a phenomenal episode today for our listeners. We have two guests joining us. I'd like to welcome to Dean's Chat Dr. Wayne Bakotic and Dr. Warren Joseph.
Hey, how are you guys? Well, yeah, I already heard how you are, but good to see you both.
Good to see you. You know, we're fairly informal on Dean's Chat, and if it's okay with you, let's go with first names, Wayne and Warren and Jeff and Joe.
Perfect.
All right. What I'd like to do is give you both a little more formal introduction. Dr. Wayne L. Bakotic began his medical training with early acceptance into the Emory University School of Podiatric Medicine. There, he completed his biomedical sciences degree through his podiatric medical studies. Prior to graduation, Dr. Bakotic left his podiatric medical training to study at Nova Southeastern University College of Osteopathic Medicine. It was, however, his time at Emory University that set the stage for his interest in podiatric pathology. After graduating with honors and completing his Doctor of Osteopathy in 1998, Dr. Bakotic continued his journey at Emory University School of Medicine, where he gained training in anatomic and clinical pathology. He remained at Emory University to complete fellowship training in surgical pathology, cytopathology, and dermatopathology, getting board certification in anatomic pathology, clinical pathology, and dermatopathology. In 2008, Dr. Bakotic co-founded Bako Diagnostics in Alpharetta, Georgia, with the goal of serving the podiatric medical community, where he continues today in the role of Chief Medical Officer. Welcome, Wayne.
Thanks for having me.
I'd like to also give Dr. Joseph a formal introduction. This is his third time on Dean's Chat, so he probably doesn't need an introduction. The first time we talked about your tremendous career, your little red handbook of lower extremity infections. You've given so much back to podiatric medicine in the infectious disease space, and including being on the Infectious Disease Society of America. The second interview, we talked about Warren's role as the editor for 30 plus years in the Journal of the American Podiatric Medical Association. So welcome back for round 3, Warren.
Oh, it's my pleasure. I mean, I'm doing this for one reason and one reason alone, the Dean's Chat mug. Wayne, you'll see, they have fantastic mugs they give you for being a guest. So I need my third mug, but thank you for having me.
They didn't even tell me about that.
There you go.
Wayne, we're breaking out a new mug for you today. It's got Bako Diagnostic and Dean's Chat on it. So you're going to like that.
Wonderful.
All right. Well, let's get started with this episode. This is going to be a little bit more scientific than we typically do, Joe. I mean, we're going to talk about some specific diagnostics, namely PCR diagnostics. And there's a long history with PCR. I mean, a lot of us in practice didn't utilize it. It wasn't available. And now we do more and more testing for fungal and even talking about bacterial testing. So with that as a background, Wayne, I was wondering if you could kind of give us a 30,000-foot view of PCRs and where it came from and perhaps how it got into our clinical diagnostics that we use today.
Well, you hit the nail on the head. 30,000 views is about all we can get in an episode like this. When you talk about PCR, you're really talking about molecular diagnostics as a general, as a whole. And quite frankly, there's a vast amount of different technologies to accomplish the molecular diagnostic goal, which is identifying things based on genetic makeup, genetic sequences. It really started, several decades ago, identifying different mutation markers, genetic markers in human disease. And it's evolved into infectious disease and infectious identification over the course of the last 15 years or so. And even still, saying PCR is really a misnomer for a multitude of different technologies that accomplish the same goal. And that's constantly evolving. It's currently evolving as we speak into things called next-gen sequencing and different sequencing technologies for identifying these gene markers that are specific to different organisms within the sample that you're identifying. So it really is a vast field, and it's evolving into being more available towards our goals in infectious disease.
Good. Warren, when did you first hear about PCR testing?
I think, it's been around for a long time because I've been lecturing on this for a while and have basically said I do think it's the future of infectious disease diagnosis with some major caveats. I mean, in one of my lectures I finished the lecture, especially when we're talking about wound diagnostics and bacterial diagnostics, I finished the lecture with a picture of the original cast of Saturday Night Live, the Jim Belushis and Garrett Morris and Dan Aykroyd, all that group, Chevy Chase. And if you remember what they called themselves or what they were named the not ready for prime time players. And I use that to kind of point out that at least in the wound world, the bacterial world, I'm not sure if we're ready for prime time yet. Whereas in the fungal world, I think it's pretty clear. I think, because of some of the work that Wayne has done and Aditya Gupta and others have done in this field, that we know now that the combination, at least for fungal diagnosis, the combination of microscopy plus molecular testing is really the sine qua non for identification of fungus, particularly when we're looking at onychomycosis. And now we also have issues with terbinafine resistance, which has been some incredible work Wayne's done. And it's just showing now, I mean, it's just rapidly increasing. He has a paper recently that in a 1-year period, the percentage of patients with terbinafine resistance doubled. So, you have this ability for fungal testing to really get the diagnosis and look for resistance markers. Bacterial is a little different, and I think it really first came into my consciousness at least 10 years ago or so when Randy Walcott out of Lubbock, Texas, well-known wound guy, well-known biofilm guru, was using this. He set up a lab, and he was using early PCR for finding biofilms, and then he did other things. In fact, that lab might still exist. I think it's Pathogenius or something like that. I don't know. It's gone through a couple of iterations. But then on top of that, he also put together like a compounding pharmacy that was doing these proprietary antibiotic gels and putting them on wounds. And so they were kind of selling this package of wound diagnostics plus what they call personalized antimicrobial care. And I'm not there with that yet. And I wasn't back then. I'm not now. And so it's been floating around and bouncing around in my head for a long time. I do think we're there with fungus. I don't think we're there for bacteria yet.
Okay, let's come back to bacteria for a minute. Wayne, I want to go back to, Bako Diagnostics has been around since 2008. When was it that you said, hey, we can use PCR for fungal pathologies? And how did that decision get made? And really, I mean, to roll it out, that's a whole effort in and of itself.
Yeah, well, to Warren's point, nails are a little bit different than wounds. You're dealing with a little bit more of a narrow spectrum of organisms you're looking for, and groups of organisms that kind of behave the same way with antifungals and things like this. So, the idea of doing PCR on a nail sample evolved somewhere around probably 2012. We started kind of working on it to get it ready to roll out. I don't remember the exact year, but the idea was culture, especially for fungal organisms, is simply just not very good. I mean, it's not very good in certain bacterial circumstances as well. specifically things like anaerobes. It's not very good at picking up and growing anaerobes and identifying them. But for fungal, organisms, culture just really doesn't have a sensitivity that's very high. You get a lot of false negatives, you get a lot of contaminants growing and things like this. So the idea was that PCR can be much more specific at identifying an infectious agent more accurately than culture can, and more consistently than culture can. So that's kind of where the idea evolved when dealing with fungal nails. But you have to remember that going back to the different types of molecular diagnostics, PCR is really a target to, a target to a primer. That's what you're doing. You're identifying one bug with a primer. You have a primer probe set, you put that in there, it binds to the DNA, replicates it if that organism is there, and that's how you identify it through multiple steps. We won't go into, but that's really a one-for-one basis. So when you're talking about PCR, you're really talking about a set circumstance of targets that you're looking for specific to particular bugs. And that's where wound comes in. Wound tends to have a lot of organisms in it. It tends to be a very dirty place because it's a superficial wound, it's cutaneous, tends to be a lot of bugs that live there. So where do you identify what's the actual bug that's causing it? And am I hitting it with these specific primers to pick up that particular organism or not? So that's where kind of we get into this realm of, are we certain that we're even picking up a pathogen, or are we picking up a contaminant? Or what does that contaminant actually mean? Could it be a pathogen in the future? We don't really, it's not as clear cut as you would like it to be when you're dealing with a wound.
Yeah, and that's been the problem. I mean, it's a multifactorial problem. As Wayne said, if you're doing a PCR, even in multiplex PCRs where you have a set panel and you're looking for specific organisms, you may miss an organism because your panel doesn't include that. I am aware of a case, and I don't want to go into specifics because I don't know if it's in litigation or not, of a podiatrist who was forced to use a in-house lab because of a group he belonged to. And that lab found, let's say, a gram-positive organism like staph. Didn't really give him any sensitivities or anything, because that's one of the problems we have. You're not doing direct testing of antimicrobial susceptibility. All you're doing is looking for genetic markers of resistance. And the patient ended up 2 days later in the hospital with a bacteremia from another organism that was not tested because it wasn't on the panel. But a simple $40, $50 culture picked up this organism that caused the patient to be in the hospital, whereas the lab was reimbursed $1,500 and missed the organism. So, that's one of the problems. When you have these specific panels, you don't know if you're missing it. And on the other hand, Wayne talked about some of this next-gen sequencing, the metagenomic testing, that's the other end of the spectrum, where you see these reports that have 30 to 40 different organisms on them, including bacteria, virus, fungus, and you don't know what, if any of it, is pathogenic. You can't just tell. Some of the labs say, oh, it's the number of isolates, the number of pieces of molecular material, the genetic material they find, and they quantify it that way. And the higher the amount of genetic material, the more likely it's a pathogen. No, we don't know that. There is nothing to say that's in fact the case. So we don't know what it's finding and whether it's pathogenic or not. A, we could be missing it if your panel doesn't include it. And B, if you're doing this next-gen sequencing, you're going to end up with this huge list of organisms, which you have no clue what you have to go after.
Joe, your thoughts on this?
Yeah, I think this is such an interesting topic because it brings in so many layers of complexity. And so for maybe a typical audience member, as you're trying to sort through kind of where you think we need to go with this, like there are some limitations perhaps in where we are right now. What are some of the things coming up on the horizon? You had mentioned some of the next-gen sequencing. Is that something that could have potential to help identify things that are pathogenic, or is it just another way to be more specific in identifying different organisms?
Well, the next-gen sequencing, the way that it functions, it was really it started its life and in many circumstances still is a research tool. What it does is it basically amplifies everything in the sample, genetic wise, and then compares all of that genetic material against a database, and they sift through it and identify every single thing that could possibly be in there. And the sensitivity is off the charts. It will pick up everything that's in there, as far as an organism in the database that it's comparing. And these are fairly well established database, structures at this point. So it's accurately identifying everything. But to Warren's point is, what does that actually mean in many circumstances? Do we treat everything? Is a doctor obligated to treat everything that the report identifies? And I think that's where a lot of clinicians fall into a potential trap, is they get a report back with 10 different organisms, 8 different organisms, and think that they have to treat everything that's in there. Well, you may be treating that patient with 3 different broad spectrum antibiotics to cover everything.
Yeah.
Well, what is that doing in the future for antimicrobial resistance? It would be a little different story if we had developed as a medical community more narrow spectrum antibiotics that were treating specific organism classes or specific organisms in general. And there you'd be able to say, okay, it doesn't matter if I treat them with 5 different antibiotics, because these antibiotics are very narrow spectrum. They're only affecting this. They're not as broad and more susceptible to antibiotic resistance. The unfortunate part is we don't have those narrow spectrum antibiotics currently. All we have are broad.
Well, the closest thing we have is phage therapy, which is still, using bacterial phages, which are viruses, that is still very specific, but nowhere near being ready to use. And, as Wayne said, this becomes a medical legal issue, because if you get all of those organisms, are you obligated to treat them when we don't know whether or not they're colonizers or pathogens? I just use my personal experience. I mentioned to you folks beforehand, I had a little aspiration and pneumonia after a routine endoscopic procedure. And they treated me with broad spectrum antibiotics. I had like 5 days, which is the current standard for broad spectrum antibiotics combinations. And we're 2.5 weeks out, and not to get personal, but my GI tract is still not the same. I mean, a single dose of antibiotic can blow out your GI tract, change your microbiota, your GI microbiota for years. So you've got to be really, what Wayne talked about with using different antibiotics and trying to hit all these different organisms. That's an anathema to this whole concept of antimicrobial stewardship, which is what everybody in ID and everybody in pharmacy is looking for now, which is using the narrow spectrum antibiotic for the shortest period of time to avoid antimicrobial resistance. And as Wayne said, we use all these different antibiotics to kill all these organisms and may not even be causing infection. We are driving antimicrobial resistance. That is the last thing we want to do. And that's where I have a problem with some of these sequencing modalities.
And I will just jump in though and say it's difficult for the treating physician when they're treating a patient, because antimicrobial resistance, they're looking at that in context to their patient, not what's going to happen 10 years from now. They have to treat their patient and do it the best way that they can. So they're not necessarily thinking about potential resistance that could occur 8-10 years from now when they're treating these patients now.
Right.
And I think that's where there might be a little bit of a disconnect. Being able to identify.
I think we have to think that way, though, because we're in the situation where we are entering what many people have described as a post-antibiotic world, where, because of multi-drug resistant bacteria, we have organisms that are resistant to all known bacteria. So it's not 8-10 years in the future. And I understand medical, legally, practically, yes, we want to use the antibiotic that's going to be best for what we have found in our patient. but I also want to make sure that we're using the antibiotic that's necessary. And when you get this list of 10 different organisms, if you try to cover all 10, as you said, Wayne, I think we're going to be using antibiotics that are unnecessarily broad, which are drivers for resistance, are drivers for Clostridioides difficile, are drivers for, antibiotic-associated diarrhea and other adverse events. So it's not just looking at the risk of antimicrobial resistance in the future, it's also antimicrobial adverse events, antibiotic adverse events, which can happen very, very quickly with a single patient with antibiotics. So that to me is the missing link. We have the bacteria that the either next-gen sequencing or the PCR, the multiplex, whatever is giving us. And how do we now marry that to our proper antimicrobial therapy? Where is that connection that says this organism needs to be treated with this antibiotic? And that's what we don't have yet when using this sort of molecular testing, I think.
So do you think, similar to how they look at some of the fungal cultures, they'll run, I know Bako specifically will run the PAS stain, they will do a culture, and they will also run a PCR analysis. And those three tests combined can be very powerful to help us determine exactly what we're treating and what the next steps are. Do you think there is utility in the future for combining something like biopsy with some of these results? Do you think that that would have utility or benefit?
Well, there's certainly more benefit to, put it this way, histopathologically, under the microscope, we can't tell what a bug is. We'll see bacteria there. We can't tell what it is
Sure.
under a microscope. It just doesn't work that necessarily that way. But when you talk about doing biopsies for culture or for PCR, you're certainly getting more accurate information from a clean punch biopsy of a wound that's been appropriately cleaned and debrided and everything else. You're getting a much more accurate look of the organisms that are there that may be causing a problem. Culture has inherent issues with certain bugs. We've already mentioned that. PCR doesn't have those issues as far as detecting the bugs it's looking for when you're talking about PCR with specific primers and probes.
Yeah.
But like Warren said, I think that we're perhaps identifying too many things, number one. Number two, I don't know that just looking at the microbiota of a wound, that it necessarily tells you if it's a biofilm or if it's not a biofilm, because that carries significant implications with therapies. Your antibiotics are going to be inherently resistant if there's a biofilm there.
Right.
So I think that the assumption is that all chronic wounds have a biofilm and you treat them accordingly. So again, where does the PCR play that role? What is it actually telling you? Because you're assuming there's a biofilm there anyway, and you're treating it with debridements and antiseptics as opposed to systemic antibiotics until it's infected.
For sure.
So, I think that the different technologies, combining them isn't quite the same as you get with fungal and fungal nails. But certainly, and again, I don't think that necessarily culture and molecular really go together that well, because if it grows, we identify it pretty well. I mean, we use mass spectroscopy, so it's not a quote unquote molecular diagnostic test, but it's a very efficient and accurate way to identify an organism, and it cuts the culture time down. So molecular cuts it down a little bit more, but it gives you a little different set of information.
As Wayne said, and you talked about biopsy, Joe, also that I think osteomyelitis is a good example of a place where molecular diagnosis may be helpful. Alan Block has done a lot of work in this regard. And I think that, where you have a clean biopsy, you're going through a clean site, you're going into an area that has relatively low bacterial load, pulling that out, and there, because we know that culturing of osteomyelitis is not particularly effective. I think some of these advanced techniques, some of these molecular techniques may help identify the organism, because you're going to find one or two organisms. You're not going to find 30 different organisms like you would with a wound, you know.
And I think that's an excellent point, Warren, because where molecular diagnostics for infectious disease has really been much more beneficial, in my opinion, has been in areas where you have a more sterile site,
Right.
CSF,
Yeah.
where you're thinking that there may be a central nervous system infection, bacterial infection. That CSF is going to be basically a much cleaner sample. You're going to be looking for one or two bugs in there. So if you identify them, you're fairly certain they're pathologic.
Yeah.
It's not
Bacteremia.
necessarily a question.
Bacteremia
So,
is the same thing, you know.
and
Yeah.
they do a lot with orthopedics, with implants and things like this, where culturing it really is not very good.
Yeah.
Molecular diagnostics, where it's a deep infection, you're looking for one, maybe two bugs. Other than that, you're getting a more appropriate set of information that's actionable, as opposed to a wound that may be actionable, may not be.
Yeah.
And we have to kind of guess.
I can definitely, that makes a lot, sorry, Jeff, that definitely makes a lot of sense just in terms of, how best someone could take some of this information and use it in a way that is very clinically applicable. And certainly in a situation where the likelihood of amplifying lots of different organisms, some of which may be pathologic and some of which are not.
Right.
And based on the results of that analysis, it may actually alter what you do to treat that patient. Those are going to be lower yield or less useful settings, where in a situation where there's high risk of not detecting an organism in an otherwise sterile-ish environment, we want to amplify whatever might be there to catch it and identify it. I can see how that would have a lot of utilization. So thank you. I think that was a really important point. Back to you, Jeff.
I was going to comment on osteomyelitis and proximal margins. I know there's a company in Colorado that did optical coherence tomography that could potentially look at a margin and from a histopathological perspective, give you an opinion, not a bacterial opinion. So there's a lot of cross technologies, right, that could potentially work.
Absolutely. Absolutely.
I was going to mention more.
We don't know the clean margins actually makes that much of a difference anymore.
Right.
There's been a couple of papers recently that have shown that it doesn't really matter with long-term outcomes whether or not you have clean margins or not. Clean margins always used to be the holy grail of treating osteomyelitis surgically. But some recent papers have shown there's really no difference in outcomes whether you have a clean margin or you don't have a clean margin. So that's what's so cool about evidence-based medicine. And as Joe and Jeff know, I run the course on evidence-based medicine at the Arizona College. And things just change all the time. And, the literature just changes all the time. And that's why the whole purpose of my course is to try to get the students excited about keeping up on the literature, because this stuff that we've held as dogma for so long is just goes by the wayside. It just makes it kind of fun. Anyway, sorry, that was an aside.
I like that aside. I think as I'm kind of processing all you're saying, a lot of studies could still be done, really delineating everything we're talking about and pushing the envelope a little bit for, comparing it, kind of like you do with TCPO2s and systolic pressures and trying to combine them in dialysis patients. I mean, there's so many different areas that we can put together for research. And I think it's wide open for that in the wound space. I recall doing a clinical trial where they had us do a PCR and we were forced to do cultures and PCRs at that study. And when the results came back, the patient wasn't infected. It was part of the protocol. But yet I had all these bacteria. And to your point, should I treat it? Should I not treat it? Of course, we didn't treat it as an infection, but those are some of the limitations. And I agree with you, but we sure would like to see some of these technologies move forward in a way that's clinically beneficial to the docs and the patients.
I think it's inevitable. I mean, I think that molecular diagnostics, like them or hate them or be indifferent, they are going to be the future in every field of medicine, basically. So, I mean, do I think it's not molecular diagnostics has no use in wounds? No, that's not what I'm saying. I think that it needs to evolve. I think that there's going to be some evolution of the process of the information that you're getting back that's going to be more helpful and narrowed down to where it has actionable utility in a patient, as opposed to just getting everything thrown at you.
Yeah, and Wayne and I've had this discussion that that's where this needs to come together, get the results, and we need to somehow correlate the results of the testing with the clinical utility of those results. And how do we find, as he said, the actionable information?
Yeah.
Which of those organisms need to be treated? What antibiotic can you use? Because again, there is no direct susceptibility testing. All you get is you get a readout on resistance genes. And I will tell you, the average pod doesn't know a MEK-A gene from a VAN-A gene from, and any of those genetic markers. So the labs try to make them readable. I don't know. It's just, we need to get that together. We need to marry together the results we get there with the tremendous sensitivity and the tremendous specificity, and match that to clinical utility. And that really is where we need to go in this field. And as Wayne said, and I mentioned before, they're not ready for primetime players yet. We're there for fungus. I think we're there for fungus. I don't think we're there for bacteria yet.
And can I ask a clarifying point on why you think it's there for fungus? And yet, I think I have the answer, but can you clarify that? Like, why for fungus and not for bacteria?
Well, when you look at work, for instance, that Wayne's done with the Geisha gupta, and they've combined, it's probably 200,000 specimens they've looked at, and looking at the combination of the genetic testing, the molecular testing, plus microscopy you mentioned, like PAS and GMS and all those others combined, by far the best sensitivity, even though the FDA still requires culture and KOH in order to test new antifungals. We know that the literature is there, the work he's done, the work others have done. It's really amazing.
But to your point, Joe, I think that when we say it's ready for fungus, I think what we're talking about, or what I'm talking about when I say that, is for identification. When we get into antifungal resistance, we start to fall. It's a little less prominent in fungus than it is in bacteria, but we start to fall in the same type of scenario. When we do terbinafine resistance, the squalene epoxidase mutations, that covers almost all mutations that would confer resistance within dermatophytes. But when you talk about itraconazole resistance, that's a different ballpark. About a third of them are caused by genetic mutations. About a third of them are caused by efflux pumps, upregulation of protein pumps. And that's where you get into with bacteria. You can identify resistance genes. Doesn't necessarily mean that the phenotype of that bug is going to be resistant. All of it. It just means that that gene is present. Okay. Perfect example is MEK-A. A lot of people associate MEK-A with MRSA. But MEK-A is present in a lot of staph organisms that doesn't confer resistance. So it confers resistance when dealing with Staph aureus, but not some of the others. So just its presence doesn't necessarily mean that there's a resistance there. It just means that the gene mutation's there, that the gene's there. So when we say we're ready for, in fungal nails, it's ready for identification, there's still some work to do there with being able to identify pure resistance in some of these bugs that aren't dermatophytes. And there's been reports of some dermatophytes that have resistance due to increased upregulation of drug efflux pumps, which allows them to overcome the bug that you're giving, or the drug that you're giving them. So it's just not as prominent in dermatophytes as some of the other organisms.
Yeah, the bugs are always going to be smarter than we are.
I'm gonna say the more you know, the less you know.
Yeah.
All right, very good. And Warren, it warms my heart to know that you're not relying on hope and guessing in the evidence-based medicine course.
No, I am trying to make the point that there needs to be some sort of evidence. But yeah, even then it gets complicated, because you're looking at evidence. If you look at the evidence-based pyramid, they always put like systematic reviews and meta-analyses are at the very top of the pyramid, which drives me a little bit nuts, because how many times have you seen a systematic review with meta-analysis where they can set the criteria they want to find the papers, they'll pull 1,000 papers, and then they do their analysis based on 5 of them. It's like there's just so many places in there for bias to come in, and you can have systematic reviews and meta-analyses with absolutely opposite. Oh my God, I shouldn't have done that. I was an important call. You see, you made me miss an important call, doctor. But anyway, the systematic reviews with meta-analysis, you can have 2 on the same topic with absolutely diametrically different opinions and results. So I just want people to understand that. I want people to understand that they need to keep up in the literature. Talking about, I get every week, I get from my NCBI, I get 3 emails with PubMed readout of one on osteomyelitis, one on onychomycosis, and one on diabetic foot. In fact, just today's Monday, there was a paper came in from Bangladesh, in fact, on onychomycosis, showed 71% susceptibility to terbinafine in dermatophytes, which means there's almost a 30% resistance to dermatophytes. That was an interesting paper. It just brought that up. But that's the sort of thing you just need. It's so easy. The medical literature is advancing so quickly, and so many papers are coming out. Mix of qualities, but so much is coming out, and we just need to be able to be up on that and know what's going on. Anyway, that's my soapbox. I'll get off of it.
Well, I'm just going to piggyback for just a very, we don't need to totally sidebar, but part of the other issue, help me understand if I'm incorrect, when you're performing a really good systematic review, if you're going to run a meta-analysis, your subsets need to be comparable. And oftentimes why you end up with 5 of 1,000 papers, you can't compare these different groups because the metrics that they're looking at, they're not comparable. You're not really looking at apples to apples. You have, shish kebab to apples. And like, you can't take those 2 papers and call those results similar.
That's
and so,
ideal. That's
yeah,
ideal.
and so it's
but
so
you still look at
interesting.
heterogeneity. I mean, look at the heterogeneity ratings on the studies, and they're so off the wall that we don't really know if we can compare one study to the other. I mean, yes, that is the ideal, that is the idealized idea. How's that for a ridiculous statement? That's the ideal of doing a systematic review with meta-analysis, is in order to combine like to like.
Mhm.
That's why I love looking at forest plots, and with a single picture, you can determine, lots of data, and you can see what the outcome is of lots of data points. But if you look, there's so much heterogeneity in any of these studies, just because we don't have better data.
That's actually a really nice segue. Jeff, do you mind if I ask a not sidebar question, but it's pertinent to the topic.
Go for it.
Do you, and we'll start
Jeff
with
likes
you.
this. He hasn't had to say anything this entire program.
Well, I talk way too much, so that's part of one of my flaws. Do either of you think that some of the advent with AI and the opportunities that it might facilitate some of this kind of research, being able to take large amounts of data from something like a PCR and use in ways that I'm not even smart enough to figure out yet, help us piece out some of this question about what might be pathologic versus what is just present? Do you think there's opportunity there? We'll start with you, Wayne.
Oh, absolutely. I mean,
Yeah.
I think AI is going to replace doctors in general. It's going to be able to process medicine, the information, the diagnostic information so rapidly and accurately. I mean, I don't think that's going to happen in the next 20, 30, 40 years. But at the same token, I think any scenario where a vast amount of data has to be analyzed, AI is going to be beneficial.
Mm-hmm.
And that's when you're talking about these with wound PCR, with an AI can ingest all of this information, comparing it across the board population wise.
Yeah.
It's going to be able to pick out the bugs that are most likely to be your causative agents and treat them accordingly. Because in general, Warren, some of these organisms work in conjunction with each other, especially in biofilms. An organism that wouldn't normally thrive does thrive in the presence of another organism.
Yeah.
Because that organism's either supplying something that it needs or it's protecting it in some way. So AI can look at these large data sets and say, okay, because of this combination of bugs, this is most likely what your pathogen is, or your pathogen complex is, and needs to be treated. So
Yeah,
yeah,
and
absolutely. I
that's
think AI is going to be in there.
That's a great point, because Walcott started talking about it a long time ago, and Armstrong's picked up on that somewhat. This whole idea of pathogen-related groups, which is just like you said, Wayne. I mean, you have a list of 10 organisms. Any of those organisms by themselves may not be pathogenic, but organism 1, 3, and 7 combined may be synergistically pathogenic. And I think that is something that we don't know. And yes, AI does have tremendous ability to do that. I don't think you're looking 20, 30, 40 years out, though. I think that it is growing much too quickly. And I think we're looking maybe 10 years out. There's just a paper, again, on one of my weekly feeds, just I looked at today, that looked at infectious disease consults, and they looked at the AI's recommendation on antibiotics based on what an ID or an ID pharmacist would do. And they found that they were pretty good, but not quite there yet. I think that that's not going to be long, because it is, I don't know enough about AI. I don't do ChatGPT. I don't do anything, but just from what I've seen and what I've read, within months to years, few years, that's going to all come together, and we will be answering to our overlords or
Yeah, I
AI
don't use it.
overlords.
I don't really use it either. I saw a Terminator, not
Yeah.
doing it.
Did you see where the USMLE Step 1 exam was fed into AI and spit out 100% correct answer immediately?
Oh, that doesn't surprise me at all.
Yeah, no, me neither. But the timing, and then, we talked to Andrew Lundquist, who's with Nablo, which, you bring your computer into a patient room and it does your chart, does your billing, and you walk out and you're done. It seems that, like you said, Warren, seems closer than further away.
Yeah,
I was trying to be a career optimist.
well, you see,
See, I think there's so
younger.
much
You're
good.
still
There's
younger,
so much
Wayne.
good that's in here.
Joe is younger. You guys still, you'll have a career. Jeff a little younger, but Jeff and I, we're on that end that whatever happens at this point.
I think there's so much potential that, yeah, there's some scary things that probably I don't have enough understanding to really understand the scary stuff. But I think there's so much good in the potential of answering questions at a rate right now that take us so much time intensive, rate limiting steps, that we can fix that in a blink of an eye. That will allow us to ask the right questions and beget new questions off of those answers. And I mean, at some point it is an algorithm, it's ratios and that sort of thing, probabilities. But if you start to ask the right questions to the probabilities and you can connect those links, that is a human thing still at this stage, that we're not yet replaceable, but perhaps when I'm retiring, we'll start to get there, but I doubt it.
Oh, see, I look at the microscope. I basically look at pictures all day. AI is pretty good with pictures.
There's been some really interesting work on dermatologic diagnosis using the different learning models, and it is damn good with taking pictures of a skin condition and making that diagnosis. So you're right. I mean, it might not be long for a microscope. Sorry, Wayne. It was a good run.
Wayne, I have a question for you. So between
Sure.
anatomic pathology, clinical pathology, and dermatopathology, which areas made the most advance, and which areas have the most room to improve?
As a field, if we're talking about microscopic AI, that type of a scenario, I think derm has done the most.
Okay.
Certain areas of anatomic pathology have done things like prostate biopsy, breast pathology. But as a whole, dermatopathology, there's algorithms for most neoplastic processes in derm.
That's fascinating. I think maybe procedure based. I mean, there's going to be robots and things. I'm thinking ahead, to our replacements.
The rate limiting step right now is the FDA. in honesty. I mean, a lot of these algorithms are being used in Europe, in Israel, in Europe, other parts of the world, because they don't have the same regulation that we have. But even there, they're used as a double check.
Oh,
So in Israel, there's algorithms they use for prostate biopsies, looking for prostate carcinomas. But what they do is they get the pathologist diagnosis and then they run them all through AI and see if there's a difference. It's a kind of a double check
that's interesting.
type of scenario. But all of these systems currently, at least to my knowledge, all of them have to be a secondary. They can't be used for diagnostics. They have to be used as a double check to the pathologist. A pathologist can make a diagnosis and then feed it through an algorithm and see what the algorithm says, and then go back and review it. But they can't use it as a diagnostic test.
Gotcha.
Is where we stand right now.
These are kind of some cool, interesting questions that cross my mind. How often in the lab, looking at a microscope, do you have to call over one of their buddies and say, "Hey, check this out. This is different. What do you think?"
So we have cases every day that we show around.
Right. Okay. Kind of like radiology.
Yeah, every one of the pathologists at Bako will show cases around every day.
That makes sense. So it's not that cut and dry.
No, well, it's usually things that, are melanoma versus not melanoma, a little bit more subtle lesions where you're like, okay, let me get somebody else's opinion, then we'll talk about it and see where we want to go. Some inflammatory things that you're just like, okay, well, this has kind of features of a couple of different things. Let me see what somebody else thinks. So that's fairly common in pathology, though. That's not, and most pathologists don't sign out 100% of their cases and just go home for the day. Usually there's some, maybe 1 or 2% of their cases that they're going to show to somebody else, get another consult just to get clarification in case they're missing something. That's not uncommon at all.
Okay, that's interesting. That's good to know. I guess I really didn't think about it that much.
Well, it's easy for us because we just have a slide and we just carry it to somebody else's office and they look at it. It's hard to take your patient to someone else's room.
There you go. That's true.
It's a little easier on my side.
So if AI takes care of all the diagnostics, we still got to have entrepreneurs, and we still have to have relationship builders and everything. So we're not going away anytime soon.
No. I think medicine is just going to evolve. It'll evolve into what it needs to be. So yeah, it's not going anywhere. But AI is going to certainly be a big part of it going forward.
Right. Oh, Warren, just so you know, I'm guilty. I've got ChatGPT on my phone, and I put things in it, and it scares me, so I kind of shut it down.
I've just read so many interesting answers to questions that have been posed to it, and I just look at it, and it's pretty amazing. So I am a techno nerd to an extent, but that's one area of technology I'm just kind of been a little hands off with. I think I'm afraid of it.
There you go. Well, we're running a little short on time. Joe, you have any last minute questions?
No, I think we're going to have him back and have more conversations because there's all these new questions that we'll just have to save for another day.
Absolutely. And we are indeed going to be sending you a Dean's Chat cup, Wayne. And Warren, you're going to get one too. And then the new ones have Bako down the side.
We don't have them yet.
So
excellent.
So when you get it, fire over a picture. Make sure you got it. And thank you for joining us. What a wonderful discussion. Appreciate it. I appreciate all Bako does for the profession, Wayne. What an incredible company that has given back at every level of our profession.
Yeah.
Well, we appreciate the words, and thanks for having me. We enjoyed it.
Thank you for joining us. And Warren, thank you as always. I mean, what could possibly be more important coming through on your phone than hanging out with us on Dean's Chat?
Oh, come on. I mean, what else am I going to do? This is crappy, sunny 70-degree day up here in Sedona. What better thing do I have to do than to talk to you guys?
That's what I figured. All right. Just wanted to confirm that. All right. All right. Well, to all of our listeners,
pleasure as always.
Thank you, Warren. To all of our listeners out there on Spotify and Apple Podcasts, thank you so much for joining us. Please give us a 5-star rating and maybe leave some comments. If you're watching on YouTube, by all means, become a subscriber and also leave a couple comments. And until our next episode, everybody, cheers.
Cheers.
Oh, I like him to hold up the cup. That's cute.
We're good. All right. Wow. You know what? I thought that was outstanding.